This chapter is going to deal with respiratory diseases. Most of these are infectious, but we're going to cover a variety of respiratory diseases. First one is upper airway obstruction. We're going to discuss upper and lower airways. We'll start with upper airway obstruction, and the most common one that you're going to see is croup. Croup is most commonly caused by parainfluenza virus. There's 1, 2, and 3. Lesser causes of croup include respiratory syncytial virus and adenovirus and other viruses. Number 1 is going to be the parainfluenza viruses. You have to know your ages again when we talk about the child. Croup is much more common in the younger child, 3 months old to about 5 years of age. One of the reasons that children get into respiratory problems is that they have smaller airways. The smaller they are, the child, the smaller the airway. So a small change in airway diameter, be it upper or lower airway, can cause a 4-fold increase in resistance to airflow. So that if you already have a small airway and you make the diameter smaller, bigger increase in resistance, they get into trouble. Plus the fact that the younger the child is, they'll have different respiratory mechanics and they can get into trouble a lot easier. The majority of croup is going to be seen in the winter. So again, when you're reading test questions, not only do you need to know the age and the sex, you need to know the time of the year. Croup is much more common in the winter. It is a subglottic inflammation. It's characterized by a barky cough, and so we're going to do a little bit of a croupy cough for you. It's a barky cough, and sometimes they'll have an inspiratory stridor. They'll describe it as barky or brassy or like a seal or a puppy, and it goes like this. So you can hear that inspiratory stridor sometimes after the cough as they breathe in. It's really a clinical diagnosis. You do not have to go out and get viral swabs and things like that. It's basically a clinical diagnosis. You hear the fact that they've had upper respiratory symptoms, usually for a couple of days, a cold, now progressing, and then this barky cough. You've got the diagnosis. And the treatment is basically supportive. You can use humidified air. If they're having problems, you can use oxygen. You can also use nebulized epinephrine. When you do nebulize epinephrine, do be aware that you can have what's known as the rebound effect. It wears off, and sometimes the swelling can come back worse. Kind of like people that use nasal sprays for nasal decongestants, they have that rebound effect. And certainly corticosteroids, dexamethasone in particular, intramuscularly or even by mouth sometimes now. They'll use it by mouth. But dexamethasone or corticosteroids are also helpful with that swelling that occurs with croup. This is the typical finding that you'll see with croup. They call it the steeple sign. So on the neck film, you get a PA of the neck, and you'll see this narrowing where the arrows are. They call it the steeple sign. They'll call it the pencil sign or a wine bottle sign. Most commonly look for the word steeple sign. That's a clue that they're discussing croup. Epiglottitis is another upper airway disease. It is usually a bacterial infection. It used to be almost exclusively Haemophilus influenza type B. Since we've been using the vaccine, now Haemophilus influenza type B is not so much a perpetrator, but you will see staph and strep, strep pyogenes, strep pneumonia, staph aureus. Also remember mycoplasma is now starting to be a common cause of epiglottitis. Look for, in the very young patient, incomplete immunizations. Then you would be suspicious for Haemophilus influenza type B. It is a year-round disease. This is going to cause severe swelling of the epiglottis. These patients look a lot sicker than a patient with croup, and they don't have that typical barky cough that you'll hear with croup. These patients will be leaning forward, they may be drooling, they can have high fevers, and they have what's called the sniffing position, where they lean forward, hyperextend their heads, and try to breathe that way, because that way they're getting a somewhat straighter shot of air and less resistance as they breathe in. Remember, because of that enlarged epiglottis, there's increased resistance to air movement into the lungs. The diagnosis will be made on laryngoscopy. This is an airway emergency. If you suspect that the patient has epiglottitis, don't waste time getting the x-ray that shows the cherry red epiglottis. You better mobilize your team to secure an airway. And the most experienced person at securing airways should be the one that gets the first try. On laryngoscopy, you will see this very enlarged, what they call the cherry red epiglottis. lateral films of the neck will show what's known as the thumbprint sign. I'll show you that in a second. So the diagnosis is really, if you see a child like that, don't waste time getting CTs of the neck or x-rays. You prepare to intubate. And you can see the cherry red epiglottis as you're intubating. So here you see a patient that has a very inflamed epiglottis. All these pictures basically show that. Here is the area, and right there where the arrow is pointing, that little area there, that is the airway. That's a very small airway. Here, again, an inflamed epiglottis, and this area right here, that is the airway. That's a very small airway. Again, look for the cherry red epiglottis. And on the lateral of the neck, you see here, this area right here is the hyoid bone. When you look at the lateral of the neck, look for the hyoid bone, and then look straight back, and right up here, this area right here where the white arrow is, that is called the thumbprint sign. That's a very inflamed, enlarged epiglottis. While I'm here at this one, I'm going to show you, I want you to look at the retropharyngeal area. These look normal. These retropharyngeal tissues look normal because when we talk later on about retropharyngeal abscesses, you'll see a completely different x-ray. So this looks normal. Look for that cherry red epiglottis, and on x-ray look for the thumbprint sign. But again, this is an airway emergency, and don't waste time getting films. Prepare to intubate. The treatment, once the airway is secure, is antibiotics, covering for the common causes of it. And after a couple of days, the patient's pretty much extubatable. They don't even need steroids because the swelling is not inflammation in that sense. It's basically from infection. Bacterial tracheitis, as we're working our way down the airway, is most commonly caused by Staph aureus. Usually you'll see this in a child that's less than 3 years of age. Again, it is a fall and winter type disease, usually after an upper respiratory infection. That's when you'll see that the patient will start to develop persistent cough and will have swelling of the upper airway. Also, they can have purulent secretions, and they'll have what's described also as a brassy cough, similar to croup. And they'll have high fevers. However, they don't have the drooling or the dysphagia that you see with epiglottitis. The diagnosis, the definitive diagnosis, is made on laryngoscopy, and the treatment would be antibiotics. Sometimes they're sick enough that you may need to secure an airway. Spasmodic croup is a variation on infectious croup. Spasmodic croup, the trigger is going to be usually some kind of virus or sometimes allergies, and even sometimes a psychosocial trigger. This is usually a 1 to 3 year old, a little bit younger than the crouper. We said the croup baby was 3 months to about 5 years. Epiglottitis is usually about 3 years to 7 years. This one is about 1 year to 3 years. So you really should know your age ranges when it comes to these diseases. More commonly, it's a patient, as opposed to viral, the viral croup caused by parainfluenza virus, where they have a URI symptom for a few days. Many times with spasmodic croup, these babies go to sleep, and all of a sudden they wake up in the middle of the night with that horrendous cough and inspiratory stridor. Okay? And they tend to get a little bit better during the daytime. The diagnosis is clinical. There's no specific test for this, and the treatment is usually just supportive. The patient gets better with time. Laryngitis, okay, this is caused by viruses, usually. So it's, again, and it can attack at any age, but again, it's going to be more common in the wintertime, like a lot of the other viral diseases. These patients will have URI symptoms, cold, cough, runny nose, and then over several days, they'll start having hoarseness, and they'll actually lose their voice. And it's out of proportion to the findings. They don't have a lot of systemic findings like shaking, chills, or anything like that. They will just basically develop hoarseness. The treatment here is also going to be supportive.